So now we are going to be moving to Mr. Christos Tolias, consultant neurosurgeon at King's College Hospital. Very fortunate to him up all the way up north, Manchester, this afternoon to give this speech. So just a little bit about Mr. Tolias is that he's the lead neurovascular surgeon at King's College Hospital. He led in reorganising the neurovascular service at King's and promoted and expanded surgical management of stroke with innovative neuromonitoring of malignant stroke. Mr. Tolias performed the first non-occlusive laser-assisted high-flow ECIC bypass in the UK. Director of the first RCS-accredited neurovascular fellowship in the UK, also Associate Clinical Director of Trauma at King's and SE Trauma Network. Mr. Tolias, the stage is all yours.
Excellent. Can everyone hear me? Hope so. Excellent. Thank you for the introduction. Thank you for asking to come up in Manchester. It's a delight to be here, and I'd like to talk to you a little bit about, after all of this very high science hematology that you had in the first part, which was very nice for me because I learned about a lot today, which I usually don't do in conferences. So this is really helpful, and thanks, guys. I enjoyed it. I'll give you my view of a little bit of what we do in neurosurgery in relationship to sickle disease, particularly with regards to aneurysms and also the stroke aspect of the condition and the secondary moya. I don't need to tell you about sickle. You know it better than most, but there are obviously some significant neuro complications that come with a disorder, with a problematic, which can be an issue. And it is well recognized that probably 1 in 4 patients suffering from sickle will develop at some point in their lifetimes, particularly as they live much longer, some sort of neurological problem, varying from aneurysmal to ischemia. And the American Society for Hematology has, for that reason, suggested that we should screen patients regularly, which wasn't happening in the past. Even when I started at King's, it was not seen as something routinely done by hematologists, but gradually over the years, it became the norm. And I think now everybody's routinely screening patients for vascular problems in the brain. And that includes basically an MRI scan supplemented with an MR angiogram. That has brought up a significant number of abnormalities that we'll talk about. But we have always to be aware that these are not unique to the sickle. There is a significant number of these abnormalities that occur in normal or non-sickle patients. They are common, and we see them almost in about 2 to 5% of the population. And therefore, we have to make sure that what we see in the sickle population, for example, similar like these small aneurysms, are more common, and we are not over-treating them. There have been a lot of work that has been done to try to clarify this, and there's a lot of cohort studies that have been done, retrospective studies. Some of them were done by our department, that they try to identify these kind of abnormalities in the brain of patients with sickle disease. And it's true that it seems to be that patients with sickle have more common problems. One of the more recent ones that I would recommend if you want to read is again from our department, which basically did a review of the incidence and prevalence of unruptured intracranial aneurysms in the sickle disease, a systematic review with a standard way of doing this. And we did identify around 10 retrospective studies that were identified with those criteria. And out of those, about 105 sickle patients with 186 unruptured aneurysms were seen. In all of these studies, the aneurysms tended to be small, around 60%, anterior circulation, 76%, multiple, almost half of the population, and almost 60% were managed conservatively with good outcomes. But the follow-up period was small, a couple of years. What it is important is that we've noticed that the cumulative prevalence of, incidence of aneurysms was rather high. It was probably quite high, actually, if you compare it with the standard. With the standard incidence of aneurysms in the normal population, and even the prevalence is higher. And that is becoming clear now that those patients do develop a lot more commonly aneurysmal problems in their brains in a much younger age group and in a much smaller number of size of aneurysms. Should stop right now. So when we looked at that in our own group of patients, which we have been about 1,000 patients followed up in 2 specialist units. It was done by Professor Tain when she was with us. We did find, of course, the same, that there were aneurysms much more commonly in younger age, particularly in women. Also, however, we found that there was an incidence of subarachnoid hemorrhages, which is not a large number if you see the patient years, but they were, however, in a younger population. So we don't exactly know how common the subarachnoid hemorrhages or these cases are, but it seems that it's more common than it would have been expected by the group, by the population if it hadn't had Sickle. There have been, therefore, various publications around, particularly that would recommend regular magnetic imaging. And this is a controversial issue because a lot of finances are involved in this, and there is economics, health economics, which are against it. But in our view, and most experts, a regular imaging is important, even though sometimes we get the feedback from our hematology colleagues, well, you ask us to do repeat MRIs and you do nothing about them, which is, of course, true. But on the other hand, when you have somebody who is in their 20s or even younger, and they are going to live not a few years as is used to happen, but decades, probably almost normal lifespan, you can imagine the risk that they are facing, even if they hadn't had Sickle. So we can't just ignore that. We agree, however, we don't know everything. And this is, for example, one of these cases. This is a young guy that I first seen in 2011 with an aneurysm on the right that you can see here, down there. And then some tiny little ones in the other side. So even though it was a relatively large aneurysm in that year, he refused to have anything done. And I mean, now 12 years later, the small aneurysms remain small, but the one here is much bigger. And even though it hasn't bled, it will require treatment. And have we hadn't followed him up, we would have probably missed it. And he's still very young. He's only 27. So I think that highlights the problem as I outlined it. And that is the small ones that are there already. So how do you deal with these kind of problems? If we have a patient which we have a lot of with incidental aneurysms, we use usually the FACES score, which is that one there, that calculates a risk of rupture on an aneurysm depending on its size, how old the patient is, where the population comes from, because there are, of course, differences. And you can see that for similar small little aneurysms, as we have been talking about, if you use that standard calculation, you'll get a risk of about 0.9% every 4 years of rupture for this kind of small aneurysms. But if it's somebody is in their 20s, if you add up 5 years for 60 years in line, that risk, cumulative risk, goes up to, I think, almost 9%. So
Christos, can I just ask, that PASA score is not for sickle cell specific, is it?
no, that is standard for all patients that have incidental aneurysms. That is what we use at the moment when we actually try to calculate the risk if you and I or anyone has an aneurysm in their brain. We are dealing with a population that have a much smaller, younger population with many more aneurysms, but very small. And therefore, if we use our standard method, we should treat them. If we use the evidence that we've got, they seem to be not changing a lot, and they don't seem to be bleeding that much, but they do bleed, and they are very young. We don't exactly have the answer, but we do know, and this applies also to non-sickle patients, that there are some studies done to try to identify out of all of this cohort of aneurysms, which ones have a high risk of bleeding. There is some MRI scans that can be done. There are some differences in flow that could be used, but these are in a very early stage, and there is no real change apart from this kind of risk that we know, which if we apply to a non-sickle population is significant, in a sickle population is even more significant, but it's not clear-cut and there is no clear guidelines. So therefore, we need to start the discussion with these families, which you know very well how difficult and how also non-compliant they are with their interactions with us. And there have been some recent publications like this one, which came from, I think, Canada, where they proactively treated these aneurysms, but they basically demonstrated that it is safe to either coil them or clip them, even though they were small in the population of sickle disease, which we know anyway, but it is not clear-cut who would benefit from this type of treatment. What we suggest is that when you identify a patient with these similar problems, you refer her to a neurovascular MDT. That's what happens in King's, but obviously I suspect the same applies to all units around the country. We assess them based on size and age, and we follow them up, usually with annual MRAs, which we ask you to do in order to, as I think you do it anyway as part of your monitoring. And then obviously we are interested in seeing these and talking to these patients, basically because some of them need to understand that even though their child is very young or the individual is very young, he or she have a risk that they have to be able to cope with. Some patients are able to understand that, and they decide, well, okay, I don't want to get this risk, and we have operated on patients that have that. I have to be honest that sometimes these little blebs that we see in the vessels of the brain, or even though we think that they are aneurysms, when we went in, they were just small little vessels that were petering out, as it happens in those cases. They were infundibulum rather than true aneurysms. So it's not a clear-cut case, but it is better that we follow them up and discuss them and make a consensus opinion and decision rather than just ignore them completely, even though there is a cost implication for sure. And of course, we need more studies. That's kind of the case. And that is about aneurysms. But more commonly, the sickle disease is associated with vaso-occlusive phenomena, with ischemia and hemorrhagic strokes, which is common as well. And you know, obviously, the large studies that have demonstrated that as the age increases, the risk of stroke increases as well in these populations. Not only because of the underlying condition, but also about difficulty in treating them effectively. Therefore, the morbidity that can be associated with this is significant, as you can see. not only from in-hospital fatality, but also from post-hospital and problems that can occur from these issues. And it's not only aneurysms, but it is strokes and what we call the secondary moya, which I'm going to focus now. What do we mean by that? I mean, we all, I'm sure, have seen MRIs similar to these ones, which are post-stroke cases. You can see the difference between the two hemispheres. It's not very clear, but this hemisphere has reduced blood flow, so it is less. There is a basically scar formed there. And also on an MRA, you see the difference. You see the left side, and you can see the normal vessels. But here, the arteries have basically petered out. They have occluded. What you see is just some collaterals that are forming, which are what we call the moya, which is a condition identified in the Far East for the first time because it's more genetically prevalent there, and it reminded the radiologists who were looking at the angiograms of a puff of smoke, which what it means in moya in Japanese, and that's why it has taken this name. But this is not the primary moya that we're talking about. This is the secondary moya, or an effect of a disorder like sickle or other problems. And this secondary moya is leads to the development of these very little tortuous and friable vessels that you saw there, which could either cause an ischemic stroke or, as we age, hemorrhagic strokes. And this is what we need to try to prevent, because it's a condition that continues to evolve, and it is also related to the underlying problem. I thought that at this stage, I'll put these two studies that are there, because a lot of people at this stage will start treating patients with aspirin. There's a controversy about this issue, which we have discussed before. And these are two conflicting studies, basically. The first one in front is from the Japanese literature back in 2015, where they did a large literature review and a study there, which demonstrated, well, they suggest no treatment with aspirin, while the second one behind, which is much more recent, published last year, is from the Korean population, South Korean, where they demonstrated that their cohort, when aspirin was used in this type of conditions, they did better outcome. I think they are both correct because they bunch together the young and the older, and therefore I think, but this is a personal view, that the younger population probably will benefit from aspirin because they have more ischemic events. The older population, when they stop growing, they will have more hemorrhagic events, so aspirin may not be so useful. But as a group, I'm sorry, I just put it here and it hides it. The Journal of American Heart Association article is much more recent, but none of this is randomized. It's all registries and cohort studies.
Christos, what's your definition of old?
Somebody who has above 18.
Oh.
So somebody who's not growing, basically older, not old at all by any means. And this is again. Now I'm going a little bit about this, what we do about these cases that do present. This is the classification of moya, which again comes from the Suzuki classification, which comes from the congenital disorder. And what you can see is those vessels that are developing, which is the attempt of the brain to reclaim the blood supply that is deprived. And there is the whole of the brain has a high production of vasogenic factors that try to which create more new vessels. and it uses not only those little vessels inside it, but also the lining of the brain, the dura, creates new collaterals. So the hemisphere that we see tries to recover the blood flow that is not there by using these small, tiny collaterals. So try just to treat the angiogram, it's not appropriate because you may disturb the equilibrium that is already established in the brain. So you have to be a little bit careful before you actually say, okay, this patient has evidence of early formation of collaterals, we should do something about it. Because unfortunately, they are coping well and their brain is in a good equilibrium. You should be careful before you do it. So again, we have to monitor these patients. If they do progress, if they develop more and more of these collaterals, that suggests that they are not reaching this equilibrium. Just having an occluded internal carotid or middle cerebral with no other symptoms doesn't mean that you can do something, you need to do something. They are coping well. The formation of this moya collaterals, these are more indicative of an unstable situation, and that is what we are looking for when we decide to do something. And of course, it's not only sickle that can cause this. Haemoglobinopathies are one of the commonest symptoms, but there are other conditions which are also associated, which we see as well. But the commonest group is the sickle for us. But we do have treating patients of all of these as well. Similar. Which one? Sorry, you got me now. Benign intracranial hypertension. Sorry. This is a condition that is affects mostly all the patients. It's women usually who have a problem with their absorption of CSF in the brain. In the very rare situations, they develop problems with vasculopathy, but it's extremely rare. That's why it's small. But you noticed. From some studies that have been published in the past, as I said, for about 43% or 5-fold increased risk of recurrent stroke in patients that do demonstrate this type of moya collaterals. And this is important to know because that's why we are like to be involved in the management of these patients. And I don't need to tell you that there is no real reliable treatment of sickle apart from transplantation. There are problems, of course, patients do when they are receiving the excellent treatment that we have had before. They manage the condition very well. Fortunately, not all of the patients that I come across will comply with the treatment, and therefore, in spite of having excellent care, they remain with difficulties which we have to try to optimize to help. But there is no getting away that optimizing the sickle management is most important rather than just treatment with surgery. And of course, bone marrow transplantation may change things for some of these patients. Given all of what I've said, what we try to do is to augment this supply to the brain, and we use a sort of bypass procedure, either direct or indirect, to try to utilize some of the scalp arteries that we have, the ones that you have in front of our ears, there's superior temporal arteries, which we can use to actually go inside the brain and either in an adult or in an older individual, the direct bypass, as you can see in there, in actually supply connected directly with one of the arteries of the brain, like this, and then allows you to actually supply that hemisphere. Of course, this is a small artery at the start, but using that process I mentioned in the beginning, it augments the circulation over months and years, because a lot more blood flow goes through it and augments the brain. This is the direct bypass, which is the rare procedure. The commonest one which we use is this, the encephalodural arterial synangiosis, EDAS, which in essence utilizes the scalp vessels to stitch on the surface of the brain and allow all of this construct to create vascular feedback to the brain itself. This is the procedure we'll do more often, and I have a little video for you there, if it works, to see how we do it. Yeah, so we identify the artery on the actual surface of the skin, and we use some intraoperative method to make sure that it's filling with blood. And we are then separating from the skin. We make a hole onto the scalp, open up the dura that you see there with our knives. I hope that you are not squeamish. We then bring the artery down onto the surface of the brain that you see there, and using very fine stitches, which under the microscope, all of that, we stitch this artery onto the surface of the brain, the pia, which is a very fine membrane covering the brain itself. And that allows us basically to hold the brain against this artery and give time for all of that pedicle to grow new vessels onto the brain. This is the brain is so starved of oxygen and so starved of blood that will facilitate that process. Takes a bit longer than I like, but
So Christos, do the myomeia vessels then atrophy when
yes,
they're not needed anymore? Or?
well, that is the hallmark of especially in the congenital form. That's what should happen. We don't see it so much in this, but what I'll talk about it in a second. But they don't progress. But I'll show you what I'm doing. If I could maybe go faster. What I want to show you is when we actually do that at the end, we replace the skull back, as you can see, and using the same technique from the beginning, you can see that artery that we had outside goes inside the brain, and it works that way. There have been some. The first time that this procedure was performed was back in 1996, which is not that old, but it does. After that, hundreds and hundreds have been performed worldwide with very good results, which we use quite often nowadays. And these are some other images, some other studies that have used the same procedure, and the effects and the safety for relating to that. We tend, that's to answer your question, that what happens with the radiographic images is that they do not worsen, they do not get worse and worse. And we don't usually do angiograms to see what the after effects. We use MRAs, but this is an angiogram of that, and you can see that artery that how it gradually grows the blood flow. It's not as striking in all patients, but that is what we believe happens in these cases. In our experience at King's, we have 16 patients that we have done over the last few years, and they range, as you can see, from 2 years to 17. We have some adults as well, but these are the Sickle ones, and you can see the breakdown in how we did them. We published this a few years back. We had only one post-op complication. We increased seizures in one patient. None of them required further revascularization procedures, and follow-up with MRAs, as we said, demonstrated that they did not progress. But there was also no further clinical evidence of ischemia. and those had no further infarcts, but also a lot of them continued in full education. And I can't stress that enough. We try to demonstrate the effectiveness using similar methods, because a lot of these patients who have these constant infarcts, even though they're well, they become less and less effective, and they drop out of school. They can't progress. And we think that if we protect them from this type of microinfarction or ischemia, they can get better. You can see again here what I was talking about the stability of the picture, and the MRA that shows that procedure there gives the flow of blood that we wanted. This is one of those patients that I was talking about. He was 14, and he needed monthly blood transfusions. He had left MCA infarct with right leg weakness, demonstrated no flow, and then gradually he had more and more secondary moya. We did a right-sided EDAS in 2008. He had some residual weakness, of course, following his previous infarcts, but he continued to improve, and not only improved from radiologically, but also from his psychosocial impact. We used a questionnaire that you may be aware of, Strengths and Difficulties questionnaire, which it's a screening questionnaire to actually identify how they improved and what kind of social interactions they had. We try to do that in all of our population, but unfortunately, again, these families are difficult. They don't come back to us in spite of our effort to demonstrate that they need to get in touch with us. But those that we managed to do that, and they did demonstrate that they continue with their studies, and they did behave much better than we would have expected with their condition. So that is all I wanted to tell you. Please don't get too worried when you see scans like this, but also don't ignore them, and do develop a relationship with your neurosurgeons, so polite neurosurgeons most of the time, who will be very keen to get involved and help with this type of problems. Although I do accept that a lot of my colleagues are not very experienced, let's say, or do not understand the condition. We also subspecialized in neurosurgery, and therefore we also have our own problems, of course. Thank you.
This is fascinating. I didn't know anything about this. Because you have the growth of new little vessels, why are they not prone to bleeding? Like, why is it better than the moya vessels themselves?
Because we don't know. It's not the ones that are developing intracranially. They are much thinner and longer, and they are more prone to bleeding. Those are just on the surface of the skin. They don't go deep. They are not the long perforators that you see in that picture, and they are stabilizing the picture. It's actually it's nothing to do with the vessels themselves. It's with the imbalance of flow. So when the brain has demands on when we actually normally function, like now I'm talking to you, my blood flow is increased in parts of the brain. If that was not fully supported by your circulation, those vessels that suddenly will need to dilate, they can't do it very well, and they burst. So by having this collateral circulation, though the rest of there's no need to do that so much, we think, and that's the reason probably, rather than just the same vessels themselves.
Sorry, in your series, you picked those kids up post the stroke.
Yes.
So and did you know if the TCDs were?
Yes, I mean, in the past, they tend to do only TCDs and try to find the stenosis alone. It's good for non-invasive method, but I don't think it's enough nowadays, because they don't pick up those subtle changes that happen before the stroke. Often, yes, in the past, we tend to treat patients after they had the stroke. but now we pick them up earlier because they have this MRI scan routinely, even without symptoms. Well, I mean, we don't do them. I can't give you an exact answer, but I think it's becoming part of the routine follow-up of patients when they come into the hospital for their normal follow-up every year, or at least every other. They do them. Some of them will have, a couple of them will have some minor ischemic events, and after that they follow. That's definitely the case. But I think it should. There is an argument about it. This, don't get me wrong. It's not foolproof. It's a lot of health economics involved with that, but overall, I think it's worthwhile because a lot of these are missed and not necessarily picked up as they should be.
I think it would be great. Hopefully, Dr. John Green is joining us this afternoon, who is academic lead for paediatrics at the Royal Children's Hospital in Manchester. That's a great discussion or question for him. He attends. Kelsey, do you have any online? Any questions? Oh, Lisa. Joe?
Just about, I'll talk about neurosurgical expertise in the UK. There's obviously your centre of experience, but other centres in the UK might not see as much sickle, and so we would refer the patients to our regional centre. Do you think we need to do anything to try and make sure that all centres have the same experience?
It's a big question, but most centres will have a vascular team that would be involved with this type of cases. So they may not have the interest to deal with them, but as always, this kind of things becomes super regional as well. So we have been having patients coming outside London as well, but it doesn't. There are rare conditions, and obviously not everybody can. It's not that the type of procedure we are talking about is so difficult or that they can't be done locally. It may be that there isn't the interest to do them or the number of patients to do them. So
we can be reassured that we're from our regional centres.
Oh, absolutely. And colleagues, because we talk about it, if they have an issue, they always communicate and they deal with that. If, on the other hand, you have been finding a little wall there, I'm more than happy to be contacted, and then I can liaise with my colleagues and we can internally try to move things forward if that's what.
Or would you see patients if from other regions?
Yeah, of course, obviously. Yeah, absolutely. We refer them to our MDT, we go through them, and then if we need to, sometimes we don't need to see them. But if we do, of course.
It's just a comment rather than anything else, that we've had a patient who's about 19 who absolutely had pneumonia at the outset and had TB meningitis, very bad TB, had EB shunt, and most recently he's paralysed waist and below, but now he's got quite severe moya, secondary moya. I don't think we're doing anything about it, and treating the TB, which is proving to be really difficult.
Well, that's a very difficult case, obviously, but you can have to appreciate that if he's going to have a general anesthetic on top of everything else, it's going to be even more difficult. So you have to balance this.
Yeah.
However, he's young, and then obviously if he's deteriorating, has he got any function in his arms and legs?
Yes, waist and above. But they felt it was paradoxical reaction to the infliximab for his TB treatment caused some of the stroke. This boy came to study in the UK and never knew what sickle and disease was, but his brain imaging looks shocking.
I understand. Well, I mean, this is the type of case that we need to see a little bit more carefully, but I can't give you an answer unless.
I think we're going to bring it to the national team and then have some input from the wider team as well.
Yeah, of course.
So we have just have one hand raised on line. Is anyone else in the room? Sorry, before we go. So they just Claire?
Yeah, but thank you ever so much for a fascinating talk. We don't find too many of these in the Yorkshire and the North East because we don't routinely carry out screening MRI scans. And I'd be really interested to hear your views and views of others in the room with regards to whether we should be doing that. There's been talk about doing a baseline scan when people come to adult services, and then maybe a scan every 5 years. But you know, I don't know if we have an evidence base for that making a difference going forwards.
Well, I mean, we went through that. There was a paper in my presentation which they tried to answer this question. It's not an easy question to answer. I think they suggested because of the higher incidence of abnormalities, it should be used, although they have a question mark there. The risks are there, but I think at least a baseline should be used nowadays. It's a lot easier than it used to be, and how many afterwards depends if that shows anything. If it shows nothing, and there is no point of doing it every year. But if there is a small aneurysm or some narrowing, then that's the ones to follow. Obviously, it's not going to be everybody, but there is a significant subgroup of those patients that have problems, and they should be followed up.
Yeah, I think my concern might be patients for whom it's not clear that they need intervention, but we're introducing anxiety, you know, an additional test when there's already quite a high burden of screening and treatment for these patients.
Yeah, so I suppose it's a question, and it's a question for everyone else. If you're putting them on a long-term anticoagulation, and if you know they've got moya, it might change how we manage these patients if they've got quite significant disease. I suppose it's a question. I don't know what's right, what's wrong, but it really opens up a lot of discussion.
Correct. But at least they should have at least a baseline, or if they develop some symptoms, we should definitely screen them, because even then, unfortunately, they don't. Traditional neurologists tend to be averse of doing scans. Or he has a stroke, he's recovered. So we need at least, we have to start with those that have symptoms, and then, of course, decide about the rest.
Yeah, thank you.
Great. I have a very mundane question. How long does this operation take? I mean, you showed us a little video. It looks very easy.
It takes about 5 hours, so it's not that big though. Fine. For us, it's not that big.
See the pulsating. Yes.
It takes more time to dissect this little artery than it takes to actually do the rest of it. So that's it.
That's really good.
Thank you.
Thank you.